Hello everyone, welcome to Pharmacology illustration series. We will specify this video and the next one for a quick revision on principles of physiology of the autonomic nervous system. This is the background we need to be able to understand the mechanism of action of all drugs in this chapter. Of course, we don't need to explain all principles of physiology. However, certain points must be clarified to be able to comprehend principles of pharmacology in this chapter. First of all, you should know that autonomic nervous system is the division of nervous system concerned with regulation of autonomic function, which means all of visceral functions we have, as those of intestine, lung, heart, or whatever, are not controlled at the conscious level, but are under control of the autonomic nervous system, which has two divisions, the sympathetic and the parasympathetic systems. And in each system, we need to discuss four elements, which are higher centers, nerves, chemical transmitters, and receptors. In this video, we will explain the higher centers, nerves, and chemical transmitters, saving receptors for discussion on the next video. Now, let's concentrate on this drawing here. This is the brain, the spinal cord, and here we have the higher centers. We will color the sympathetic system with red and the parasympathetic system with black. These are the higher centers that control all autonomic or visceral function of the whole body. When we say higher centers, we are talking about them collectively. To be more specific, we have centers here on medulla and centers above in the hypothalamus, above which are centers in the reticular formation, and then we have centers in the cortex. Centers in these levels are called higher centers. And now we can control the autonomic function by drugs that act on these centers. In this chapter, we will have many drugs which control the autonomic nervous system by acting on these centers. These higher centers will send nerves passing through spinal cord. Red color is for sympathetic nerves, while black one is for parasympathetic nerves. This autonomic nerve supply will reach any organ. So, let's take the heart as an example of the involuntary control of the autonomic nervous system on such organs. Here you see a dual nerve supply composed of sympathetic and parasympathetic nerve fibers. And many, but not all, internal organs have dual nerve supply of sympathetic system and parasympathetic system nerve fibers. To summarize, nerves is coming from higher centers, passing through the spinal cord until it reaches the internal organ and end with what is known as nerve terminal. And those nerve terminals of sympathetic system are different from those of the parasympathetic system. Before discussing how they are different from one another, you should know that autonomic nerves don't travel the whole distance as one segment, like motor nerves do. However, autonomic nerves must firstly relay on a station called ganglion, which is composed of collection of neurons. This ganglia act as a power station regulating the strength of signals before reaching the internal organs. Any autonomic nerve must relay on ganglia, and in case of parasympathetic system, ganglia are situated near the organs, but in case of sympathetic system, ganglia are found very far from organs and close to the spinal cord. That's why it's called paravertebral ganglia. And this difference is a rich source for questions. An examiner may put you through the following scenario. Imagine if you were in a lab And then we isolated a rabbit heart and gave it to you and told you to apply a certain medication on it. Now tell me, how can the drug affect the isolated organ? Your answer as a student will be like this. The drug can act upon nerve terminals, either sympathetic or parasympathetic. And it can also act on a receptor, and that is reasonable, because nerve terminals act by releasing transmitters that activate receptors, so the drug can indeed act on a receptor. But if you say the drug can act on ganglia, here the examiner would ask you to be more specific. And if you say sympathetic ganglia, then you have fallen into the examiner's trap. When we isolate an organ, it comes with its parasympathetic ganglia only, as it is always situated close to the organ site. So when a drug is applied to an isolated organ, it can act on a receptor, nerve terminals, or parasympathetic ganglia specifically. Now you may wonder if all internal organs have dual supply of both systems. The answer is most, but not all, have dual supply. However, nerve supply of both systems to an organ is rarely equal. Sometimes the ratio of nerve supply is 50-50. Sometimes one system is given 80% of the autonomic nerve supply to an organ, while the other is only contributing by 20%, down to some organ which have single supply of only one system. For example, single sympathetic nerve supply is found in suprarenal glands, which is considered as modified sympathetic ganglia. Sweat gland also have only sympathetic nerve supply. And most importantly, the blood vessels, which are mostly supplied only by sympathetic nervous system. Now you know that most organs have dual nerve supply, except in some organs which have single supply as mentioned before. Here we have talked about higher centers which send fibers through spinal cord, giving rise to nerves that supply our internal organs. And most of them have dual nerve supply, but some has single supply as those mentioned before. Now we need to look at the signal, which is generated in the higher centers, then it passes through the nerve till it reaches the ganglia, where the signal in the form of electrical depolarization causes release of chemical transmitter called acetylcholine. In this state, acetylcholine is termed neurotransmitter. Then acetylcholine opens a gate inside the ganglia. This gate is considered as receptor, termed nicotinic acetylcholine receptor. This type of receptor is ion channel receptor that will be discussed in the next chapter of general pharmacology. You will know that this type of receptor is the fastest one that can respond to acetylcholine among all other types of receptors. So now, after the acetylcholine is released inside the ganglia, it opens a gate named nicotinic acetylcholine receptor, causing sodium ion influx, causing depolarization. That's because during nerve transmission, we need a fast responding receptor type, which is nicotinic acetylcholine receptor, which will generate another signal in the postganglionic fibers in the form of depolarization wave till it reaches the nerve endings. Again, signal is coming from higher centers as depolarization wave, passing through nerves to reaching the ganglia, where it transforms from electrical into chemical form. So depolarization wave releases acetylcholine. Acetylcholine opens a gate termed nicotinic acetylcholine receptor. When this gate opens, postganglionic membrane becomes depolarized, and signals come in this direction. So, when postganglionic fibers are depolarized, depolarization wave reaches nerve terminals. Then, same scenario will happen again, as these vesicles filled with acetylcholine will rupture, causing release of acetylcholine, which acts on its receptors present on this organ, now termed cholinergic receptors. And what are these cholinergic receptors that are found in many organs called? It's called muscarinic receptors. And we have three well-known types of muscarinic receptors termed M1, M2, and M3. M is short for muscarinic and the number is for the subtype. So we have M1, M2, M3, and we also have M4 and M5, but those two are of little significance. These are the muscarinic receptors, which will be discussed in detail but not right now. This whole system is called parasympathetic system. But what happens in the sympathetic system? It is nearly the same as parasympathetic system. Higher centers send signals. However, preganglionic fibers in sympathetic system are short, as ganglia are situated close to the spinal cord. Yet, same process occurs again as depolarization wave reaches ganglia, causing release of chemical transmitter, which is also the acetylcholine. Then acetylcholine opens a gate called nicotinic acetylcholine receptor, and when the gate opens, it causes sodium ion influx, causing depolarization in the postsynaptic membrane. Then signal continue as depolarization wave till it reach sympathetic nerve endings. However, this time, nerve endings doesn't release acetylcholine. Instead, it releases another transmitter termed norepinephrine or noradrenaline. And tiny amount of fibers release epinephrine, but most of them release norepinephrine. When vesicles rupture and release noradrenaline, noradrenaline acts on a receptor. So what do we call this receptor? Do we call it muscarinic, cholinergic? No, this time receptors are termed adrenergic receptors. And what are adrenergic receptors we have? We have 5 adrenergic receptors termed alpha 1, alpha 2, beta 1, beta 2, beta 3. Now I ask you, do all internal organs have all of these receptors? Or does the heart has M1, M2, M3, alpha 1, alpha 2 and so on? Of course not. Organs tend to choose 1 or 2 receptors at max. For example, heart chooses M2 when it works under parasympathetic rule, so that we call M2 cardiac M2 receptors. That's because the heart doesn't have much of M1 nor M3, but mainly M2 receptors. And same goes for sympathetic, as most of sympathetic receptors on the heart are of beta 1 subtype, which predominates all the other types. Others may be present like alpha 1, alpha 2, but they are of no significance. Beta 1 receptor predominates them all, so that we call it cardiac beta 1 receptor. To summarize, all internal organs have dual supply of sympathetic and parasympathetic. These two release chemical transmitter that activates receptors. However, organs don't have all types of receptors. Instead, one of each type predominates the other, and they always have antagonistic function. So, if one is increasing the function, then the other one is decreasing it. Now you may ask, what is the benefit of such antagonism? This antagonism prevents the organ from being controlled by only one force. For example, when one is activated causing tachycardia, The other one can antagonize it and causes bradycardia. But where does the problem come from? A patient may come to you complaining of tachycardia or rapid pulse. Now you understand that this problem, tachycardia, is caused by overactivity of sympathetic system, and this beta receptor is overactive, causing increased heart rate. So how can we treat this patient? We can give him a drug that either blocks this beta receptor or activates the antagonistic M2, which is able to counteract the effect of beta receptor. On the contrary, a patient may come to you complaining of bradycardia. So, tell me, what's causing this problem? Yes, it's the parasympathetic system, and we can give him a drug either blocks M2 receptor or activates beta receptors, so they can reach equilibrium. This background you now have enables you to understand any autonomic malfunction and how can you treat it. So, can you tell me now what are the methods of controlling the autonomic nervous system? First of all, we can control the autonomic nervous system at the level of higher centers. Secondly, we can control the autonomic nervous system at the level of ganglia, either sympathetic or parasympathetic ganglia. Right? We can control it by manipulating the function of those ganglia of autonomic nervous system. Can we? No, we can't control the autonomic nervous system at the level of ganglia. But why cannot we control it at the level of ganglia? It's because you already know that they have the same chemical composition. Both of them, either sympathetic or parasympathetic, have the same chemical transmitter, acetylcholine, and the same receptor called nicotinic acetylcholine receptor. So a drug blocks acetylcholine release is a non-specific drug as it blocks both sympathetic and parasympathetic ganglia, which leads to depression of all autonomic function throughout the body. And this drug lacks a very important quality, which is not being selective. You can't target acetylcholine or its nicotinic receptor because in either way you would be blocking both divisions of the autonomic nervous system. Previously, there were drugs known as ganglion blockers and others called ganglion stimulants. However, these drugs are no longer used due to lack of selectivity. So, if an examiner asks you why ganglion blockers are no longer used, you can simply answer because they are non-selective and they act on all ganglia and thus we can't control their effects. As such, ganglion blockers would cause depression of all autonomic ganglia, either sympathetic or parasympathetic, and this is a complex effect we do not desire in medicine. Now back to the original question. Can we control autonomic nervous system on the level of nerve endings? Yes, we can. Why? Because nerve endings in parasympathetic system release acetylcholine, but in sympathetic system they release a different transmitter called norepinephrine. Here we can select one division and target it with a drug acts either on parasympathetic nerve endings which release acetylcholine or sympathetic nerve endings which release norepinephrine. So the second level we can control autonomic function at is the level of nerve endings. Thirdly, and this is the best option, which is controlling it at the level of receptors, because here I can choose even a subtype of receptor from either divisions. In this chapter, we will discuss a group of drugs called beta-1 blockers that can block beta-1 receptors only, or beta-1 and 2 blockers, or alpha-1 blockers, and so on. And this is the best route being highly selective. So, to summarize, can we act on higher centers? Yes. Can we act on ganglia? No. Can we act on nerve endings? Yes. Can we act on receptors? Yes, and this is the best route, being highly selective. The next step, after having understood the function of nerve endings, is the fate of transmitters. Transmitters released from ganglia as acetylcholine or any other transmitter. We have to understand the fate of transmitters to decide if it can be of any value in the science of pharmacology. Now let's focus on this concept. After acetylcholine is released inside ganglia, either by sympathetic or parasympathetic stimulation, and perform its function on the receptor. What happens to acetylcholine? What is the fate of acetylcholine? You should know that acetylcholine, after performing its function on the receptor, must be broken down immediately in a matter of milliseconds. Whether this acetylcholine is in the ganglia or the nerve endings, it's broken down by the action of enzyme called choline esterase enzyme. This is the fate of acetylcholine after performing its function on the receptor. We have two types of choline esterase enzyme: true choline esterase and pseudo choline esterase. The fact is, true and pseudo are pretty old. Now true is called acetylcholine esterase and pseudo choline esterase is called butyryl choline esterase. And the differences between those two enzymes are of utmost importance. Now we know that acetylcholine, after performing its function, it must be broken down by either of two enzymes. This true choline esterase is specific, which means it only breaks acetylcholine. However, pseudo or butyryl enzyme is non-specific, which means it doesn't break down only acetylcholine, but also other chemicals are destroyed by this pseudo enzyme, such as heroin, a well-known drug. It also breaks down procaine and succinylcholine, which will be discussed later and is used as pre-anesthetic medication, used before surgical operations as skeletal muscle relaxant, for induction of skeletal muscle relaxation before surgical operations. This drug is used by anesthesiologists in certain doses, taken into consideration that it is destroyed by this enzyme called pseudo-choline esterase. This is about specificity, but what about the site? Since it's named true and it is specific for acetylcholine, then you can find it in all vital areas such as ganglia, CNS, and even red blood cells. But why does true choline esterase present in red blood cells? Do we actually have acetylcholine in our red blood cells? This question will be answered later. However, pseudoesterase is produced by the liver, and thus you can find it in the liver and is also present in plasma. Again, why does pseudocholine esterase present in plasma? Do we have circulating acetylcholine? This is the same question as the first one. However, this question will be answered now. Do we have circulating acetylcholine in our plasma? No, we don't have acetylcholine circulating in our bodies. So, why do we have pseudocholine esterase in plasma? The answer is because it is not specific for acetylcholine, so it's present in plasma to break down many other compounds such as heroin, procaine, succinylcholine. Even sometimes you may eat food that contain choline esters, substance similar to acetylcholine. and those choline esters can enter our blood, causing problems. That's why we need such enzyme in our plasma, and that's why it's sometimes called biological scavenger, which means it can remove any choline esters, whether ingested or injected. Now, regarding the importance of both enzymes, if I give you a drug blocks this choline esterase enzyme, you die, because it is essential for life. However, this one is not so much, because it is not so important in breaking down acetylcholine, but for metabolism of other drugs. And regarding inhibition of both enzymes, true esterase requires 3 months to be regenerated again. However, pseudoesterase only need 2 weeks to be regenerated again. Okay, here we need to look on the pseudocholine esterase. Now you know that it is needed for metabolism of other drugs than acetylcholine. Among these drugs are succinylcholine, a muscle relaxant drug used before operation to induce muscle relaxation. But do you know some people have genetic disease with the gene responsible for pseudocholine esterase synthesis is not present? A child may be born and live his whole life without knowing that he doesn't have the gene responsible for choline esterase synthesis, or the liver synthesize abnormal form of the enzyme. I have told you this enzyme is not essential for life. But when does the problem occur? This person can live without any problem, but if he have an operation where succinylcholine is used, the anesthesiologist consider that 90% of this drug is metabolized in circulation. So he must calculate the dose of succinylcholine because 90% of this drug is metabolized before reaching skeletal muscle. So before obtaining the desired effect on skeletal muscle, 90% of the drug is eliminated by pseudocholine esterase enzyme. So the amount of drug that escapes the action of the enzyme and reaches skeletal muscle to produce its desired effect are only 10% of the given dose. Now imagine if this child who inherited a defective gene from his parents and didn't know this bitter fact, went through an operation where the full dose of succinylcholine was administered. Those 90% of the dose won't be metabolized and 100% of the dose would reach the muscles, causing not relaxation but muscle paralysis. And this patient on operation table after administering succinylcholine to him would start to realize he can't even breathe. And now he needs a ventilator in order to survive until the tiny amount of pseudocholine esterase in his plasma can metabolize and eliminate this drug. This is a fatal case of pseudocholine esterase enzyme deficiency, and because it leads to respiratory inhibition, it is sometimes called succinylcholine apnea. Now I hope you understand the importance of this background in order to be able to understand the function of the autonomic nervous system and how can we interact with this function.